Welcome to the Department of Health's online information modules for the National Aged Care Mandatory Quality Indicator Program, also known as the QI program, for residential aged care services. This module is part of a suite of resources available to help services to understand and meet their obligations under the mandatory QI program. During this session, we will take a closer look at the second quality indicator, or QI, use of physical restraint. We will discuss the why, what and how of collecting and submitting data for the use of physical restraint QI. We will also touch on QI reporting and how to use service level reports to track progress and inform continuous quality improvement. By the end of this session, you should have an understanding of the objectives of the QI program, physical restraint and some of the reasons why restraint may be used, the importance of monitoring the use of physical restraint, QI program requirements for the classification, data collection and reporting of the use of physical restraint QI, and where to access further information about the QI program. So what is the QI program? From 1 July 2019, participation in the QI program became a requirement for all government-subsidised residential aged care services. It is now mandatory for residential aged care services, including respite services, to submit QI data to the Department of Health every 3 months. The following programs are currently excluded from the QI program: flexible care, including transition care, the short-term restorative care program, multi-purpose services program, the National Aboriginal and Torres Strait Islander Flexible Aged Care Program, the Innovative Care Program. The objectives of the QI program are for providers to have robust, valid data to measure and monitor their performance and support continuous quality improvement, and, over time, to give care recipients transparent, comparable information about quality in aged care to aid decision-making. The QI program may benefit your service by providing a set of meaningful and measurable QIs to assist your service to monitor and improve important aspects of care, enabling your service to monitor and identify trends in their performance over time, compare with other services, and implement improvements that will promote a quality of care and quality of life, and, over time, through the publication of information about the QIs, the QI program may enhance community understanding of the high-quality care your service provides and assist care recipients with choices and decision-making about their care. The QI program involves specific methods for collecting, recording, submitting and interpreting information about the QIs. It is important for the reliability of the QI program that your service uses the methods exactly as prescribed in the QI program manual. The QI program currently includes 3 QIs that address important aspects of quality of care in clinical areas. These are pressure injuries, use of physical restraint and unplanned weight loss. Each indicator has categories for which data is collected through assessments and measurements. Data needs to be collected for a total of 10 categories across the 3 QIs. We will explore each of these categories in further detail as we look at each of the QIs. Let's take a closer look at the second quality indicator, use of physical restraint. So, what is physical restraint? For the purposes of the QI program, restraint is an aversive practice, device or action that interferes with a care recipient's ability to make a decision or which restricts their free movement. Physical restraint means any restraint other than a chemical restraint or the use of medication prescribed for the treatment of or to enable treatment of a diagnosed mental disorder, a physical illness or a physical condition. Legislation, through the Quality of Care Amendment minimising the use of restraint principles, requires that physical restraint must only be used as a last resort. A restraint-free environment is the recommended standard of care. Evidence for the prevalence of physical restraint suggests that physical restraint is used in some form for between 12 and 49% of care recipients in residential aged care. The evidence also indicates that restraint does not prevent falls or falls-related injuries and is actually likely to exacerbate challenging behaviours. You can read more about the evidence for the use of physical restraint QI in the QI program manual available on the Department of Health's website. So, why is monitoring the use of physical restraint so important? The use of physical restraint can have a significant impact on the quality of life of care recipients and can have negative physical and psychological effects, including pain, decreased cognitive function, infection, pressure injury development, falls, and even death. So, what are we measuring? The use of physical restraint quality indicator is collected and reported using two categories, counting each care recipient every quarter. Category 1 is the intent to restrain and Category 2 is the use of physical restraint devices. Let's take a closer look at the terminology used in this quality indicator. The definitions of physical restraint are provided on page 16 of the National Aged Care Mandatory Quality Indicator Program Manual, available on the Department of Health's website. These definitions include intent to restrain is the intentional restriction of a care recipient's voluntary movement or behaviour by the use of a device, removal of mobility aids, or use of physical force for behavioural purposes. This category requires observation and recording of any instance where any restraint equipment or action is in place to intentionally restrain a care recipient using devices or actions contained in definitions A, B, or C. Physical restraint devices is about counting all devices in use at the time of the assessment. The list of devices in definition B is a complete list for the purpose of this category. These are to be counted whether they are being used to intentionally restrain a care recipient or not. You should note that family members or legal representatives do not have the legal right to request that a care recipient be restrained. To get the most accurate information possible, it's important that everyone collecting the data does this based on the classifications, measurements, and assessments prescribed for each QI. This information is contained in the National Aged Care Mandatory Quality Indicator Program Manual, which is available on the Department of Health's website. The QI Program Manual supports a consistent approach that allows services to compare results across collection quarters with other services, as well as against national averages, by prescribing methods for classification, data collection, and reporting of the QIs. Information from existing data sets, for example incident reporting systems, must not be used where information has been collected differently to QI program requirements. A total of 9 observation assessments must be completed for each care recipient every quarter. The 9 assessments include 3 assessment days at approximately the same time each quarter. Each assessment day involves 3 assessments, one at each of the approximate times of morning, afternoon, and evening. There is flexibility as to the precise timing of each morning, afternoon, and evening assessment, dependent upon what works best for your individual service. However, all measurements and assessments must be done exactly as described in the QI Program Manual. These instructions include that every care recipient must be assessed for intent to restrain and physical restraint devices, including respite care recipients. Each care recipient must be told about the assessments and ask for their permission to include their data in the QI program. If they withhold permission, note this in the comments section of the data collection sheet. Observation assessments must be unannounced to staff and care recipients, and where possible should be conducted by staff not directly involved in providing care. Secure areas and perimeter alarms are not included in the use of physical restraint QI. Now, let's take a look at a few scenarios. This part of the session is a mock data collection. The mock data collection will work through the morning, afternoon, and evening observations for one of the 3 observation days in the reporting cycle. For the purpose of this exercise, we will look at 3 care recipients, Mr. Seth, Mrs. Jaya, and Miss Brown. However, note that you are required to observe all care recipients, including respite care recipients and those receiving end-of-life palliative care. Okay, let's get started. You work at the ABC 123 Residential Care Service. Your organisation has split shifts across the day, so you have decided that you will do the morning observation and your colleague Harry will do the evening observation. You have also decided, in order to keep the observations consistent, you will complete the afternoon observation together, allowing you to discuss and compare consistency of application of the definitions. You start your morning observations. The first care recipient you see is Mr. Seth coming past you secured in his wheelchair with a seatbelt. He is in transit on his way to breakfast. Using the QI program definitions, although he is restrained, he has only been restrained during transit to and from the dining area. The QI program definitions exclude seatbelt use for this purpose, so you record Mr. Seth as 0 for Category 1 and 0 for Category 2. You continue your observations. You observe Mrs. Jaya eating her breakfast in her room, and you notice that the chair she is sitting in has the table locked across it. You investigate why she is using a chair with a locked table and confirm that there is no intention to restrain her. The table was just the closest one available when she asked to have her breakfast served in her room. As there was no intent to restrain her, this has been recorded as 0 for Category 1, intent to restrain. For Category 2, as a lock table is listed under Definition B and is functioning as a physical restraint device regardless of the intent, you mark this down as 1 for Measure 2 and place a comment on the recording sheet the device used was a lock table with no intent to restrain. You now move to the common room where you find Miss Brown watching morning TV. She is by herself in the room and you note that she has a locked table across her lap restraining her. On investigation of the restraint, you note that one of the team locked the table across her lap because she was sitting by herself and they were worried that she would fall out of her chair. As the restraint was intentional, you record this as 1 for Category 1, and as a lock table is listed as a physical restraint device under Definition B, you count this as 1 for Category 2. You have now completed your morning observations of all care recipients. For the afternoon, you have decided to complete this observation with Harry to give you a chance to compare your understanding of the definitions to make sure there is consistency across all 3 observations. You start the afternoon observations where you, once again, will observe all care recipients. The first care recipient you come across is Mr. Seth. Mr. Seth is strapped to his chair with a seatbelt during his shower so he would not fall out of his chair. Unlike earlier in the day, he was not in transit at the time of the observation and as such is not excluded under the definitions. After a little further investigation, you find that the family requested that he is strapped into his chair for his own safety during his daily showers. Regardless of the reason behind the restraint, this is still counted as intentional restraint under the program definitions and counts as 1 for Category 1. As he is strapped in his chair with a seatbelt, which is listed under Definition B, this also counts as 1 for Category 2, use of physical restraint devices. You note in the comments that the restraint was used during showers at the family's request. Next you see Mrs. Jaya. She is in a water chair as she is immobile and can no longer walk. This was done to prevent her falling out of her chair. You note that the water chair does not restrict her freedom of movement in any way. As her freedom of movement has not been restricted in any way under the definitions for Category 1, this does not count under intent to restrain. Although the water chair can be used as a physical restraint device, it is not listed under Definition B for Category 2. On the recording sheet, you record this as 0 for Category 1, intent to restrain, and 0 for Category 2. In the next room, you come to observe that Miss Brown has been locked in her room after she had become agitated with another care recipient. As Miss Brown has been intentionally locked in her room, this shows intent to restrain and, as a locked room, is counted as a physical restraint device under Definition C. You record this as 1 for Category 1. For Measure 2, although the locked door is used as a physical restraint device, it is not listed under Definition B and so is not counted for this category. You record this as 0 for Category 2 on your data recording sheet and add comments for future reference. This completes the afternoon observations. Harry starts the night observations. In the first room, he observes that Mr. Seth has both bed rails pulled up. On investigation, he finds that Mr. Seth has pulled them up himself so that he feels safer. Harry counts this as 0 for Category 1, intent to restrain. Under the QI program definitions, the 2 bed rails in use are counted as 1 physical restraint device in Category 2. The reason for this counting method under program definitions for bed rails is they need to be used in conjunction with a secondary device to physically restrain a care recipient. Bed rails are commonly used with either a second bed rail or a wall to form the restraint. In this case, the bed rails are used in conjunction with each other to form the single restraint device. Harry next observes Mrs. Jaya, who feels safer having her bed pushed up against the wall. As Mrs. Jaya can get out of the other side of her bed, her freedom of movement is not impacted in any way. As she is not restrained, this is not counted for Category 1 or for Category 2. Harry continues his observation and comes across Miss Brown. Miss Brown has one bed railing pulled up on her bed. Harry knows that Miss Brown has this pulled up during the day to assist with her mobility around the room. For Category 1, although one bed railing is in use, it is in place to assist with her mobility and not for restraint. As such, it is not included under the program definitions. For Category 2, although bed rails are identified under Definition B as a physical restraint device, in this case only one bed rail is in use, and as Miss Brown can still get out of bed from the other side, it is not being used as a physical restraint device. As such, this is not included under the QI program definitions for Category 2. This ends the first day of observations. To finalise this period of data collection, you must complete the summary data sheet in order to prepare the data ready for entry into the QI program part of the My Aged Care Provider portal. Take the total counts for Category 1 and Category 2 and enter them into the relevant section on the summary data sheet. It is important to note here that the comments you upload into the portal are displayed on your QI reports. Do not include any personal information in any of the data you submit to the department. This includes information such as care recipient names, initials, or bed numbers. You should now review the summary sheet, and when you are ready, click Next to view the data submission page in the My Aged Care Provider portal. Data needs to be transferred from the data summary sheet into the My Aged Care Provider portal. All users can enter QI data, however, only your services administrator can submit the data. If you are not the administrator, you can save and finalise the data, then workflow this to your services administrator to submit the data for the quarter. It is important to note that all data must be finalised and submitted each quarter prior to the submission deadline, which is 21 days after the end of each quarter. Your My Aged Care Outlet Administrator is responsible for submitting your QI data via the My Aged Care Provider portal. As you can see, using a summary data sheet that mimics the design of the My Aged Care submission screen will make the data submission process easier. If you are the My Aged Care Outlet Administrator and you would like to find out more about how to set up and use QIs within the My Aged Care system, please refer to the Quick Reference Guides or QI Program Manual, which are available on the Department's Quality Indicators webpage. 3 service level reports will be available via the Provider portal. These will become available 7 days after the data submission due date for the quarter. The reports include a Quarterly Facility Summary Report, Quarterly Facility Detailed Report, QI Report Graphical Displays. Any staff member or team lead can run these reports once their My Aged Care Outlet Administrator has enabled their QI role. These reports will provide a summary of your data and allow you to track progress over time. Service level reports can be used to track quality indicator data over time and identify areas for quality improvement. Multidisciplinary teams are encouraged to consider this data and any factors corresponding to increased or decreased prevalence rates. For example, due to increasing prevalence of the use of restraint, a service might introduce new staff training and support materials about how to recognise and manage the behavioural and psychological symptoms of dementia. Ongoing monitoring of service-level QI data could then be used to assess the impact of the training and consider whether this could be introduced as annual training or extended across services. These reports will allow services to view their results for the current quarter as well as compare them to previous quarters. They will also report a percentage change in the data reported against each QI. Additionally, the reports will provide the service with year-to-date averages for each measure and provide national averages for this quarter and year to date. National aggregate de-identified quality indicator data for each quarter is published on the Australian Institute of Health and Welfare's Gen Aged Care Data website. This published QI data will include national, state and territory level participation statistics across all providers and summary statistics for each QI. Data at the individual service level is not published. More information can be found on the Department's website on the National Aged Care Mandatory Quality Indicator Program page. For your convenience, we have listed some of the key QI resources. Congratulations on completing the Use of Physical Restraint Quality Indicator Information module. You should now have an understanding of the objectives of the Quality Indicator Program, physical restraints and some of the reasons why restraints may be used, the importance of monitoring the use of physical restraints, QI program requirements for classifying, collecting and recording information for this QI, QI reporting, including service level reports, and where to find further information about the QI program. When you are finished, you can end the session by closing your web browser.